Hi, everyone. Welcome to today's Compassion and Action webinar, which is entitled Colliding Emotions in Clinical Medicine, the Dialectic of Anger and Compassion. We're so glad that you've joined us here today. I'm Stephanie Adler-Yuan. I'm Director of Programs here at the Schwartz Center for Compassionate Healthcare. As many of you know, we're a Boston-based nonprofit organization. We've been around since 1995, working hard to advance compassion in every experience of healthcare. We've long been focused on improving relationships of care so that we can foster and enable healing healthcare systems, not just for our patients and families and communities, but for those of us in the healthcare workforce as well. And that's what we're going to talk about here today. So before we get started, I just want to note that today's program will last 60 minutes. We will have our wonderful speaker for the first 40 minutes or so, and then we'll have some time for questions and discussion. I encourage you to share your experiences. We've opened up the chat for today, so don't be shy, don't hang back. We want to know how today's talk resonates with you, with what you're seeing, what you're feeling, what you're seeing with colleagues. So please feel free to use the chat liberally. Feel free to engage in the Q&A as we move through the discussion. Last but not least, I want to acknowledge that this Compassion and Action webinar series has been funded in part by a generous donation made in memory of Julian and Eunice Cohen, and we're so grateful for that support. So with that, I'm going to hand the event over to today's moderator. Dr. Beth Lown is Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer here at the Schwartz Center. I know she's excited to share this incredibly important work and speaker with all of you here today. Over to you, Beth.
Thank you, Steph, and thanks to all of you for joining us. I am very, very excited to introduce you to today's speaker, who has been very helpful to me as I've thought about what it means to really care in this very challenging time, what it means to lean in with empathy and curiosity when challenged by patients or their family members, or others who, like ourselves, may be quite distressed and suffering themselves, what that demands of organizations and systems where we work, and what that demands of us as individuals. The issue is, how can we sustain ourselves in the face of such challenges? Our speaker, Dr. Christine Runyan, is a professor in the Department of Family Medicine and Community Health at the University of Massachusetts Medical School, co-founder of Tend Health, and a mindfulness teacher at UMass Memorial Center for Mindfulness. I first heard Tina speak on a podcast with Krista Tippett, the On Being podcast, which I'm a regular listener to, and I just was so moved and immediately wanted to reach out to you, Tina. So thank you so much for joining us here today.
Thank you, Beth, for that warm introduction, and for Stephanie and for everybody at the Schwartz Center for all of the work that you do. I am going to share my screen so people can follow along with slides. And here we go. And as Stephanie said, I really love to work in the space of conversation and of discussion. So please chat in, be thinking about your questions as we go along. It's really would be quite a privilege to be in dialogue with all of you. And I want to start with a very deep bow of appreciation and gratitude to all of the attendees for the work that you are doing now, the work that you probably were doing long before the pandemic started, but have been doing in a unique and, I trust, fairly intense way the last 18 to 19 months. So thank you for that. And I don't have any explicit conflicts of interest per se, but I do just want to disclose, as Beth said in the introduction, that I'm a co-founder of Tend Health, where we are extremely passionate about providing mental health services to healthcare professionals. Those are the individuals that we care for, and healthcare organizations. And it is truly from that work that I think deeply about the things that I'm going to present about, and I'm deeply indebted and again, a very privileged position to be a psychologist to so many healthcare practitioners, particularly during these last 18 months, and to walk alongside them in a really difficult, complicated, and uncharted journey. So today I'm going to talk about I tried to address these things, this relationship between anger and compassion, with a primary focus really on naming and talking about anger. I'm sure you have lots of depth in your presentations talking about compassion in particular. So I'm going to weave those together at the end, but I really want to talk about what to do when anger enters clinical practice and how to manage that. So these are my primary objectives for today's presentation. So first I want to, coming back to the title of this presentation, the dialectic between anger and compassion. And a dialectic is two seemingly contradictory things that are both true and happening at the same time. And it's really the art of how do you work with and hold these dialectics when they occur, certainly in our lives and also in clinical practice. So a couple of examples, just so you sort of get the theme of what I'm talking about in terms of a dialectic, and see if this provides a reasonable scaffolding for what many of us have experienced with anger and compassion. So as clinicians, we use evidence-based practices, and we individualize our treatment. We tweak here and there based on the evidence in totality, but we know that for this particular individual or that individual, we have to make some adjustments. As clinicians, we're very relationship oriented, and we have to meet the demands in whatever system that we work in terms of insurance requirements or other regulatory requirements that sometimes press on our relationship nature and really challenge that. Also, as clinicians, we expect patients to engage in their own self-care. We hope that they are taking their medication as prescribed. We hope that they're doing things to enhance their own health. And as clinicians, we may not always be doing the same. So these are things that feel like somehow have some conflict or tension, but are actually both true at the same time. We see this in patients. Patients don't want to be told what to do and may react when we give very explicit prescriptions or recommendations. And it's also true that they're coming for some information and sometimes can't find their own solutions. For some patients, they wish they didn't have so many problems, but they continue to use substances, which create a lot of the problems that they wish that they weren't dealing with. Patients want to be treated like adults and sometimes behave immaturely. So these are all examples of dialectics in clinical medicine, of tension points that seem to be in conflict, but actually are both true at the same time. And when we can see the dialectical nature of these, it can open a little bit more of expansive view, because we can see that, oh, this exists in nature, right? This exists in other places. So I like to get a little feel of what people are experiencing. So we're going to transition to a couple of poll questions to allow people to acknowledge and see if any of these things are here for you or have been here for you in the last 18 months. So I'm going to invite Angela on with her magnificent poll administration skills to administer a couple of polls that I would be very grateful if people would engage with, so we can just get a little bit of the pulse of what's here in terms of people's experience. So Angela, I don't see the polls on my screen.
I can read them out to you, Tina. Okay?
Yeah, that's.
Sure. Let me just pull it back up.
Oh,
So,
I see. She said it's open in another window. Nope. Yep.
Have you
Thank
got
you.
it?
Thank you. Yes, I got it. Thank you so
Okay.
much. Okay, so and I assume participants can see the results of the polls as well. So this may be an artifact in some ways of the group that comes to engage with this community, is that we're not actually seeing a lot of anger with patients. So a little bit, but most people are saying not at all, or just a little bit, and then a few had quite a bit. But it's there. It's there. Somewhat or quite a bit is certainly there. Okay. The second one, have you felt angry with leadership in your organization in the past 18 months? Great. Thank you all for participating. This is so useful to get a sense. Okay, so we have about 43% not at all or just a little bit. And then, yeah, over half, somewhat, quite a bit, or almost every day. Quite a bit of anger with leadership. Okay. And then let's go to the third poll. Have you been upset with yourself for feeling angry or having a lack of empathy or compassion in the last 18 months? Your own internal experience with this. Okay, great. So again, it may be because people have gained so many valuable perspectives and skills through being a part of this community that a pretty solid percentage can report not at all or only a little bit of feeling upset with themselves. But still looking at almost 50%, not quite, having quite a bit of distress over that feeling of being upset with themselves. And we're going to kind of dive into each of these. So thank you all for participating with those polls. It helps give me a sense and also confirms, I think, a lot of what I have been hearing and seeing in people that I work with around both the experience of anger, the direction of the anger, which is can be both leadership focused, could be patient focused, and then sometimes how it can take a U-turn on ourselves. I was working with a third year internal medicine resident, and this was in the fall of 2020 before there was a vaccine. And it was after Thanksgiving where there was, a lot of warnings about gathering together as families. And she was caring for an elderly couple who were both in the hospital with COVID. And she was feeling quite upset and quite angry and had witnessed this interchange between the couple before the man went downhill and ultimately died, saying to, was communicating back to his wife, ask her, why did she make me go? Why did she make me go to this dinner? And so feeling a tremendous amount of sadness and grief, but also a lot of anger in then continuing to care for this other patient. And for herself, not being able to see her family over the holidays, feeling very overwhelmed in her work. And she came to our appointment saying, I don't think I can be a doctor anymore. It's not okay for me to feel this angry with my patients. And so that phenomenon of like this internal experience of anger and not having a way to resolve the very human experience of anger in that setting that feels so incongruent with everything about why she went into medicine and the kind of doctor that she wanted and expects herself to be. And so that story is probably not, the details of it may be very unique, but the experience is probably not. And so I want to transition and talk a little bit more about this experience of anger as a human emotion, and then weave it back into its experience as being a clinician. So you may all be familiar with the movie Inside Out, and this is how I'm going to transition into an introduction about anger. The volume may be low for you, so you may need to turn it up.
All right, open.
This looks new.
Think it's safe?
What is it? Okay, caution. There is a dangerous smell, people. Hold on, what is that?
This is disgust. She basically keeps Riley from being poisoned, physically and socially.
That is not brightly colored or shaped like a dinosaur. Hold on, guys. It's broccoli! Yeah! Well, I just saved our lives. Yeah, you're welcome.
Riley, if you don't eat your dinner, you're not going to get any dessert.
Wait, did he just say we couldn't have dessert?
That's anger. He cares very deeply about things being fair.
So that's how you want to play it, old man? No dessert? Oh, sure. We'll eat our dinner right after you eat this.
Riley, here comes an airplane.
Oh, airplane. We got an airplane, everybody.
Okay. Oops. Okay, so anger, this very human experience of anger. And, as you saw in that clip, the idea that anger cares very much about things being fair and may not be invoked often for a lot of us, but it's very evident when it occurs. When anger arises, most of us know, oh, this is anger that's here. And anger is information. It's a very valid emotion. It often can show up when we are feeling powerless, when we feel like we need to protect something in ourselves or someone else. It is a clear sign of the stress response being activated. There's a reason anger is red in that movie. And we can sense that, right? That flushing, the activation of our sympathetic nervous system. We talk about blood boiling, right? With anger. The language we use around anger has a very physical, visceral connotation of sort of a redness, a pumping, a vitality. It's a physical experience that often we can look at somebody's body posture and their movements and how they're holding themselves, and we can intuit, oh, that person's angry, without saying a word. So it is an experience that most of us can identify when it occurs in us, and often when it occurs in other people. So I encourage you to think about, a time recently when you were angry. It doesn't even have to be in a clinical setting, to just get in touch with that sense of anger. My youngest child is learning how to drive, and I am not one that is at all prone to any kind of road rage or upset. If somebody cuts me off, my normal response is like, oh, okay, there you go. But she's learning how to drive, and there is an all-way stop on the way to her school every morning, and it's not one that comes to a clear crosshatch. So it's an all-way stop, but it's a little bit disjointed in terms of where each of the four corners meet. And people seem to not be able to understand that it's not that you just come to a stop, you stop and then you sort of go in your order. And so I think it was last week, she was at the stop, had sort of waited her turn and started to go, and another car came. And really, seemingly out of nowhere, I was like out of my seat, and I was, saying to this other driver, like, it's a four-way stop, using finger gestures. That was the finger gesture. It wasn't the other one, but I was like, it's a four-way stop. And that was I was feeling angry from a sense of protection. When it's me in the car, it's like, oh, okay. But it was her driving, and it was really out of that sense of protection that I was feeling angry, and also out of something that is probably beneath the anger. So if you think about the last time you were angry, and you could even chat this in if you're so inclined, because anger is often pointing to something else. It's often a secondary emotion, if you will. What is known as anger, like in this case for me, was really about fear. And it was also this sense of protection that was arising. I don't see anybody chatting in, but again, feel free to chat in this sense of like the last time you were angry, might there also have been something else underneath it? Because anger is often a secondary emotion that can sometimes feel a little more vulnerable to show up. Anger is a way to get our needs met sometimes, and to, again, be protective. But if we can drop into what else is here, we actually may be able to meet that anger with a little bit more skill. And I think this is true not only in our lives, but in our clinical practice as well. And when I think about anger and the emotion of anger, the experience of anger, I always come back to what's happening underneath the skin, because we as humans are actually pretty sensitive beings where we're taking in all kinds of information through our sensory experience, some of which we're aware of, some of which we're not aware of. But when something comes in that is a stress to us, and our hardware, the part of our nervous system that perceives something as a potential threat or isn't sure, and it may be a potential threat, is activated, and there is this whole cascade of response that happens when there is this potential threat. Four-way stop, car coming towards us, potential threat. COVID-19, really new, very unpredictable in the early stages, not feeling very much in control. There is a potential threat. All of us, we have the same software that we're going to run, and we're going to have a stress response and get activated. For many of us, that has been going on in a very chronic state that has been unmitigated, maybe lessened most recently, but has been very chronic. And when we have stress activation, it doesn't have to be this really extreme sense of a stress activation, like extreme fight or flight, where you're going to lift a car off somebody or you're going to run faster than you've ever run. It may just be at a low enough level to take you out of your optimal zone of arousal, right? And this is the happy place that most of us want to be as clinicians, in our window of tolerance. In this zone of physiological arousal, we feel safe. We're not feeling threatened. We feel competent. We feel competent. We can address what's coming our way. We have the sense of empathy. We can tap into the deep well of compassion. We can listen. We can listen very generously to our patients. We can tune in to what's happening with them and what's happening on our interior. And then when we get stressed at the physiological level, and that software is running in our sympathetic nervous system, we are catapulted outside of our zone of tolerance into, for most of us, a hyperarousal zone, for some people, a hypoarousal zone, where you sort of detach, numb out. And sometimes in between. Sometimes you may be very hyper aroused during the workday and come home and sort of skip right over that window of tolerance and go into a zone where you're really checked out and disconnected, and sort of, with people around you can't really access you fully. You're not fully there. I think during the pandemic, this window of tolerance has been shrunk for all of us, because we have all been experiencing even if it's at a lower level, a chronic level of stress activation. And so when we are outside of this window of tolerance, it doesn't, again, have to show up as this extreme fight or flight response. It often can show up with increased defensiveness, much more rigid thinking, things have to be a particular way, lower frustration tolerance, some irritability, and even this sense of anger. So when we're not in our optimal zone of arousal, not only are we more prone to experience and feel anger, we are more prone to act on it and express it in particular ways, and often not very skillful ways, which for many of us as clinicians is where we very much hit that tension point of, this is not how I'm supposed to be. I did not go into this profession to feel this way, to experience this. I want to be of help and I want to be of service. And so that tension point can be really deeply destabilizing, honestly, for a lot of us as clinicians. So that sense of, are you upset with yourself for feeling this way? Do you feel like you don't have a place in your specific clinical practice because you're feeling this way? Is not an unusual phenomenon because of what kind of activation is happening underneath the skin that makes us not only more prone to experience this, but also more prone to act on it, because the part of our brain that's going to help control that impulse to act on it is also compromised when we're at this higher stress level. Our prefrontal cortex, our thinking part of our brain, is intentionally a little bit compromised. We don't need to be in an analytical place if we're really trying to defend our safety and our livelihood from a potential threat. And so you actually are more likely to act on these feelings that already feel incongruous with your sense of being a clinician. And so you can see how you can get a bit of a spiral effect, and then a turning in respect of not feeling like that is authentically you. And that's a lot of what I've been hearing. And so when I think about, well, how do we combat this in clinical practice and in clinical medicine at a systems level? I will talk about some things that we can do at an individual level, but thinking about this at a systems level, both our system and then the system, when I think about, well, what does the nervous system really need from the environment to help us stay in this optimal zone of arousal? It needs physical and psychological safety, predictability, choice, belonging, connection, and recovery time. And I would love to hear from people in the chat, in the questioning, around how well does your healthcare organization provide those things? This is not a list that is sort of inherent to most healthcare settings. Some of this is unavoidable. You can't really have tons of predictability in an inpatient setting, in an ICU or an emergency room. You can have predictability of process. Recovery time is not something as a system, as a healthcare system, that we're really good at affording people to come back into their window of tolerance before the next thing hits. So these are just physiologically what our systems need. And you can see when you compare that to what is happening in your healthcare situation or organization, no wonder we have this chronic activation that's happening, because we don't have our systems built around these things that can help us when we have that activation and when we are feeling this sense of anger. And so we have a lot of activated people trying to be there for other activated people. And an activated person cannot regulate another activated person. It's just not how our systems work. When you lower your activation, you can then be there to regulate another person, but our systems are not easily providing for this. So I offer that just as a level setting and an explanation in some ways that's not in a pathological sense. If you are feeling these things, it makes sense, and you're paying attention in some way, and your system is paying attention. All of your humanity is being being agitated because of the situation at large, and then the situations in which we all are working. So we have not all had the same pandemic, and we have not all had the same information or access to the same information during the pandemic. We've had this nexus of shared experience, but we all know Black and brown communities, poor communities have experienced this pandemic very, very differently, in not even considering the larger social fabric of what we've been dealing with the last 18 months. And if we really step back, because I hear a lot of frustration around people's choices or patients' choices of not wanting to get vaccinated, and that evokes a lot of anger. It evokes a lot of frustration. And if we take a step back, we can also see, if we haven't all had access to the same information, why should we expect anything different than what we're getting? And I don't say that as a way to excuse certain behaviors, but really that the person sitting in front of you, or the person laying in the bed with you, in terms of being the place where we want to direct some of the anger or frustration, are really a product largely of this much bigger system that is not allowing them in some way to make the most informed decision. And the thing that I have been thinking about around this, how to move people in a direction towards vaccination, we're not pressing on the right levers as a society to do that, because this is not, even if there have a lot of misinformation, it's not an information deficit that usually changes people's mind. The things I think about are the social cost for many people around making a decision different than their most proximal social network. And so I'm really curious, when people are choosing not to get vaccinated, who's around them and what choices have they made? And if you can find any outlier in that, because there is a huge social cost for a lot of people to make this decision, even if they are tending towards it. And I also want to very much acknowledge that this is different than, the diabetic who is not checking blood sugars or changing their diet, or the person who is misusing substances. Let's say they're not putting anybody else explicitly at risk. I do think this situation has some different variables in place in terms of, as clinicians, we have vulnerability that's not just about the individual. It's really, people can create vulnerability in us and in people in our own homes. We don't have really choice around if somebody shows up at our hospital, right? We don't have choice to say we're not going to care for that person. So individually, you don't have a choice. You very much confront this idea that people are want to benefit from the same science that they're rejecting around the vaccine. They want to benefit from all of the scientific knowledge to help them heal and be better, but reject this one piece of it. And that's very difficult and different. And that there is a public health imperative. So it's that, if people are making their individual choice, but in this case, it's not just about them. It's about other people around them. It's really about everyone. And so I do think there are some things that are different about this particular scenario that, for many of us as clinicians, we have figured out through our journey how to stay in compassion for people who are making different choices that might be value aligned for us, or different choices that may be not in their best interest in terms of their health. We have been able to see that and stay in a place of compassion. And this one, I think, is really pressing us because of these reasons for a lot of people to feel that sense of anger that many of you did report. And so there's a Chinese proverb that says the beginning of wisdom is finding the right name for things. And I think there's a lot of power in naming. There's a lot of power to lower our own reactivity, and a lot of power in just a common starting point for a conversation to begin to name things as they are, including naming the sense of anger that we may feel. Now, I'm not saying to your particular patient, say, I'm angry at you or I'm angry with you, but to name for ourselves what this experience is without judgment, without a sense of I shouldn't be feeling this way, or this means I can't be a doctor, but to just name what is here. Naming has some capacity to draw us back into our optimal zone of arousal because it re-engages the part of our thinking part of our brain to help calm our sympathetic nervous system. And we all know this even as clinicians, right? We love naming. We love, once we know what something is, we often know what to do. Not always, but often. And so if we can name our own experience in this, we can move forward in a direction to not be as reactive in our expression of what's here. So because this is a series on compassion, I just want to come back to this sense of compassion of, a common definition of compassion. You're all probably familiar with this, which is an awareness of suffering. We often think about compassion of awareness of suffering of others with a desire to help alleviate that. And I love Paul Gilbert's definition of, awareness of the suffering in oneself and of others. I think anger can, for many people, depending on your early relationship with anger and your early exposures to anger, be a kind of suffering in oneself. And so this sense of being able to bring some compassion inward for that experience of anger, when you feel that anger, to name it and maybe to have some desire to alleviate it. And so this is where I want to invite a different way, perhaps, of thinking about anger, whether it's towards patients, leadership, or self. And I'm going to use the wisdom of David Whyte, who is a poet and sort of philosopher of sorts, who really challenges us, I think, to think about anger as illuminating something within us that we really care about. He says, anger is the deepest form of compassion for another, for the world, for the self, for a life, for the body, for a family, and for all of our ideals, all vulnerable and all possibly about to be hurt. He says, stripped of physical imprisonment and violent reaction, anger is the purest form of care. The internal flame of anger always illuminates. The internal flame of anger always illuminates what we belong to, what we wish to protect, and what we are willing to hazard ourselves for. What we are willing to hazard ourselves for. Many of you have hazarded yourself for because you are committed so deeply to the work that you do. You've hazarded yourself. And I've worked with many, many clinicians who have gotten COVID, and it's fascinating. I can't think of one, actually I can think of only one, who was angry that they got COVID. What was hard was holding the fear and holding the anticipation of perhaps getting it or getting somebody else sick. But once it happened, and once it happened in the context of their occupation, I can only think of one who I've worked with who was really angry. The others were not angry. In part, they couldn't maybe identify the specific vector. Often it was a colleague. Very hard to be angry with a colleague. It was part of, it was one of the occupational hazards, but they weren't angry at that. But the fear could be really crippling. And he goes on to say that, anger is a quality to be followed to its source, to be prized, to be tended, and an invitation. And I just love that idea that anger actually is an invitation to reveal what we care so deeply about. We care about the health and well-being of our patients, of our families, of our friends, of our society. We feel like there's some breach in this expected social contract that we're reacting to. And so when we can see the anger as what's here beneath the iceberg and what might this be pointing to, I think we're in a much different position to meet anger, not with a lot of reactivity and unskillful action towards leadership. And what I'm most concerned about is, or towards patients or leadership, but most concerned about towards ourselves. Then we can begin to look at expressing anger through constructive means. Now, what do I mean by that? There's two types of ways we can express anger, right? The experience of anger is not a problem. The manifestation of it, the outward behavior of it can be. So constructive anger is actually used to kind of stand behind an ideal with conviction. It propels you to action, but in a way that helps you protect something that you value. And often it is to decrease suffering in self, in others, in a society. So constructive anger is actually a beautiful manifestation of this uncomfortable, for many of us, emotional state of anger. When we can do it constructively. Destructive anger we see oftentimes in settings where it is quite personal, it tries to control or belittle others, and it's really reactive. And so that's the kind of anger expression that can come when we are out of our zone of tolerance, out of our window of tolerance. But when we can see anger as the purest form of care, as an invitation to pointing to what we value, we can move towards expressing it with assertiveness, with a naming of what it is. We can invite curiosity for the perspectives of others and work together collaboratively around solutions if that's relevant. And in this way, anger is actually, we could use a little more of it, if you will, in these settings to be able to move towards change and a way to meet ourselves and meet the environments that we work in a much more responsive way to our nervous systems. So how do we meet this anger without turning it on ourselves? Well, I think self-awareness is actually the bedrock of all kinds of wellness or well-being. So first is naming it, is just noticing when it's here. Where does anger live in your body? And once you notice it, to be able to U-turn in a sense and say, like, what is it really pointing to that I care so much about, right? In my case, in this 4-way stop, is pointing to protecting my daughter, which as soon as I can recognize that, it's not that I have to do anything towards this other driver. It's a reaffirmation of something that is so valuable and meaningful to me. And that immediately brings me into my window of tolerance, because I don't need to do anything else at that point other than rest in this awareness that that protective factor is alive and well. It's there because it points to something I care so deeply about. So that's this process, internal process, right, of getting to those primary emotions. Any of those kind of regulating techniques. I always put what else here because I know that my audience, whoever's listening, has more great ideas than I can put on a single slide of how to meet anger within yourself in a way that is skillful and that is really true to this invitation, if you will. And then two more things that I think about in this time when there has been a proliferation of anger that feels so incongruent with being a clinician, right? These are not the kinds of things that showed up in people's medical school or residency application essays of their experience of anger with patients or with leadership, right? These are a product of the times, and understandably so. And yet, I do think around forgiveness and acceptance. And, it may not be true for all the systems that you work in. Can we offer some grace to others and to ourselves that people are doing the best they can under really challenging circumstances and can still do better, right? That's the dialectic. Doing the best you can, and there's more work to be done, right? And we can do this better. But most of us have some things that we need to forgive. Some people we may need to forgive. We may need to forgive ourselves for things left undone throughout these last 18 months. So I think about this, the way forgiveness may show up as a way to meet with anger, and the sense of acceptance, right? Being able to parse what is and is not in your wheelhouse of control, and letting down and dropping what's not, but also meeting what is in a constructive manner, with courage and with compassion. And so I probably don't have to tell all of you, when we think about that sense of compassion, and this is true even if you are experiencing a lot of anger. I work with a lot of people who are really high, right, on this high kindness for others, not so kind for themselves. They can understand when a colleague feels angry. Of course you feel that way, but aren't as generous to their own emotional experience. And so, as Jack Kornfield says, unless your compassion includes yourself, it is incomplete. And this is really, I think, the goalpost, if you will, if there ever is one, around how to come into and embody true compassion, is to invite yourself to lay down the welcome mat, to open up a seat at the table, invite yourself into that circle of compassion for whatever is here, and to know that it's coming often from a place of very deep-rooted care, and values of things that are deeply important to you and probably propelled you into your life and your work and your identity as a clinician. So with that, I will end, and I really welcome some opportunity and I'll stop sharing for any dialogue or questions.
Thank you so much, Tina. I don't know if you could see the chat. There was a very lively conversation going on.
Oh, no, I couldn't.
I'm sorry. I'm going to feed some of it back to you, though, because I think it's really helpful and important. There was a very early question about the relationship between anger and depression, and someone wondering whether they were at greater risk of depression because of feelings of anger. They said that they had heard that depression is sometimes anger turned inwards. So I don't know if you have any comments, about that.
Yeah, I think it's that sense of anger that, there's a very little real estate between anger and shame. And so I often think depression is shame is a very common bedfellow with depression, and shame for feeling angry is not uncommon, particularly if our relationship with anger gets established pretty early in our life, and gets established a lot by what we observe as a child in terms of anger with our primary caregivers and in our home, and whether or not the identification and expression of anger is welcomed or whether it is internalized. And so if the feeling of anger, and this is often true for a lot of women, the emotional feeling of anger can feel incongruous with what even sort of is expected of us or we expect of ourselves. And that can very quickly sort of feel like we have to shut that down and internalize that. So I do think there is a correlation there, and sometimes the ability to begin to name that emotion of anger, and to be able to move forward with it in a constructive way, can be one pathway of beginning to uncouple it from a sense of depression. Yeah.
It's helpful. By the way, there's just so much thank yous in the chat. I don't know if this has been responded to, but we will be posting this recording soon on our website for those of you who want to review it again and share it with others. I wanted to ask another question, Tina, though, about acceptance. And sometimes I'm puzzled by this, and I understand that radical acceptance is necessary. And yet there seems to be some tension between acceptance and sort of inertia about moving towards trying to change things, whether in yourself or in your context or organization or whatever. So how do you tend to that in a way that's positive and constructive?
Yeah.
How do you not get bogged down, by acceptance?
Yeah, and this is true on this forgiveness space too, because acceptance and forgiveness doesn't, I don't want to conflate that with sort of condoning whatever behavior is there, right? It's sort of, we don't need to sort of forgive or accept things that are inappropriate or are hostile or blatantly disrespectful. It's more about discernment, I think, around what are the things that I do have some agency and control over, and acceptance around those in which I don't. And that work of discernment actually can be very clarifying. And sometimes it can clarify things in a way where it's clear that we no longer want to accept certain things. And that again may be pointing to some breach on our values. The word integrity is coming up for me as we talk about this. Is that when somebody's integrity is breached or is challenged in a way, I don't think, right, acceptance is the path forward around that, because again, that is pointing to something that you care very deeply about. And so it may be some very intentional action within your swim lane, right, within what is within your control. And sometimes that's just raising the issue of sort of letting this be known and taking it up rather than sort of swallowing it and moving to a place of acceptance. To that question around depression, acceptance, it can lead to that sense of like learned helplessness or detachment. And as soon as we move to that place, not only do we spare ourselves from the hurt and betrayals and anger that may be there, but we unfortunately cut ourselves off from, right, the joy, the purpose, the meaning, the awe that is available. Nobody, I think, has figured out kind of how to partition the human experience in a way that only cuts us off from the things that are difficult to feel and leaves us access to the other ones. We have to sort of embrace that full continuum and full catastrophe, if you will. And so if it's that kind of acceptance, that's a different kind of acceptance than what I'm talking about, where there are some things that are truly not within our control, and our ability to accept that and work towards something else. That's the dialectic. I can accept how it is now and work towards something better.
Right. And you have to have a foundation of believing in yourself and believing in your own self-worth to be able to move towards that, so that you don't habitually downgrade your own value, your own worth, which I think sometimes that's, not too uncommon amongst women, because there's so much external cueing about that. But amongst others as well, who are less represented or marginalized in our society.
Yeah.
So there were other comments here about the bodily experience of anger. And I also have some curiosity about this. How do you use the physical sensations of anger to help you process it? What role does this sort of being aware of your physical symptoms, somatic, presence of anger? How do you think about that? How do you help people use that?
Yeah. I mean, shy of a situation in which there is truly a threat to safety and livelihood, I believe we will always be our wisest, best self when we are working from a place of regulation, when we are in our optimal zone of arousal. And so the exceptions occur in healthcare too, right? In terms of a code or something in the emergency room, a trauma in the emergency room, we default to our training. And we need a little bit of that activation actually to be our best selves in those situations. But shy of those situations, those extreme situations clinically or personally, I always believe that our wisest, most discerning, most effective, creative solutions are going to come when we are in a place of regulation. And we all kind of know that intuitively. That's really where our creativity is born, right? When we feel safe, like anything is possible, physically safe, psychologically safe. So I always work to have it be, it's like the alarm goes off. And then how do we bring the activation into a place where it feels more tolerable to have discernment and wise action? That's the place where I think we can always trust that we're going to be most effective. The strategies in getting there are going to vary person to person. So there are some, the naming technique can be really helpful. And then there's a variety of somatic kind of regulatory experiences that can be helpful. And sometimes we actually just have to discharge that energy. Sometimes anger energy is very activating and we actually can use it, right, in some kind of physicality, and then come back into that place of optimal regulation. And that would be the place that, I think to come up with, how do I meet these challenges that are in front of me now, whether those are clinical or personally.
Yeah, that's very helpful. So you use the sort of physical sensation. This is happening to me, to step into a place of being able to name and regulate. We have just 2 minutes left, but I have to ask you this because there were so many, oh my gosh. There were so many questions about this, about being sort of the recipients of the experiencing both watching suffering family members or even patients and feeling this intense compassion on the one hand and intense anger on the other hand. And again, sort of this paradox in a way. How can I manage this? Came up over and over again in the chat. And I know you've expressed a lot of strategies for us here. Do you want to wrap up with any final comments about that? Because I think that was the most common thing chatted in.
Yeah, I mean, this is where I think to know that anger, then the sense of this didn't have to happen. I hear that a lot. It didn't have to be this way, is illuminating what brings you to that very space at this point, on this day, in this moment, to be privy to what is actually unfolding before you. It is your deepest compassion and care for the human condition, for your fellow human beings, for the application of science into have people be their healthiest best selves. It is that drive that lands you in that place where you can simultaneously be feeling both of those things. And as if you can sort of shine that light, right, to see that anger is just because you care so deeply, as this really, it's just this beautiful reflection of not being cut off from it. And Roshi Joan Halifax would say, right, to have a to stand with an open and wide heart and a strong back.
Yes.
It's
yes.
just, yeah.
Yeah. So that leaves us in a place of grace.
Yeah.
Thank you so very, very much, Tina. This was so wonderful. And everybody is thanking you in the chat. I wish you could see it, but I'm going to turn this back over to Stephanie to close us out. And thank you again.
Thank you.
Yeah, thank you, Beth, and thank you so much, Tina. This was really outstanding and clearly struck a chord with the group here today who are still on, even though we're at the top of the hour. They can't let go. We're so glad for that, and thank you all, and you're welcome. We're so thrilled to be able to convene these really important conversations and to support you all in the incredible work that you're doing. So thanks for joining us. Keep an eye on your inbox for news of future events. More will be forthcoming at the end of the year and in the new year. Also coming up on November 4th, I have to say, is our wonderful celebration of the National Compassionate Caregivers of the Year Award and our annual virtual this year dinner. If you're a part of a Schwartz Center member organization, please keep an eye on your inbox for an invitation that's forthcoming. Finally, we will be sending you a very brief survey after this webinar. We love your feedback, so please take a minute to fill it out when it comes through. And in the meantime, just thank you for all you do. Thank you for your commitment to compassionate care. Thank you again, Tina. Thank you, Beth. It's a privilege and an honor as always, and take care, everyone. Bye.